Very good evening to you students, and I hope you are doing well in your homes. And yeah, we miss you all here, but see, the learning has to continue, and whatever time we get out of our COVID postings, I would like to devote it to making some useful material which you can learn in the comfort of your home. So let us begin with the aminoglycosides. We left at aminoglycosides. In the last session, we discussed about how the antimicrobial agents, they inhibit the bacterial protein synthesis. And out of that, I also told you that aminoglycosides are one protein synthesis inhibitor, students, which are bactericidal in nature. They are not bacteriostatic. So we are going to continue with the aminoglycosides, and I did mention a few aminoglycosides, and the few of the aminoglycosides are obtained from Streptomyces species, and so they are called streptomycin, kanamycin, and few of the aminoglycosides are obtained from the Micromonospora species, so that is why they are called gentamicin and netilmicin. So we are going to read today in detail about the aminoglycosides. So students, this is the cell envelope of a gram-negative bacterium. I told you that aminoglycosides have very good activity against the aerobic gram-negative bacilli. They have less activity against gram-positive bacteria, and they also have activity against some atypical microorganisms. They lack an activity for the anaerobic organisms because, the anaerobic organisms lack the oxygen transport facility, which is also required by the aminoglycoside. So if you see this outer part of the gram-negative bacterium, you can see from inside outside, this is the cytoplasmic membrane. This is the penicillin binding protein. The relevance of this we will establish when we do the beta-lactams. This is the periplasmic space. This is the peptidoglycan wall, and that is inhibited actually by the beta-lactams, and this is the outer membrane which contains the porin channels. So this is the structure of the bacterial cell wall and the cytoplasmic membrane. So now when the aminoglycosides have to go inside the bacterial cell, it is going to go through these porin channels. I told you aminoglycosides are very water soluble. So water soluble compounds can seep through the porin channels. They can't diffuse across the lipid bilayer. So aminoglycosides have a very good medium to go inside the cell via these porin channels. From there, they move inside the cell and reach the bacterial protein synthesis assembly, which they try to inhibit. So how do they reach their target? They diffuse through the aqueous channels formed by the porin proteins, as I showed you in the previous figure, in the outer membrane to enter the periplasmic space. So they from the outer membrane, this is the periplasmic space where the aminoglycosides enter, students. Now, transport across the cytoplasmic membrane is not a passive process like a porin diffusion. The transport across the cytoplasmic membrane, this is the cytoplasmic membrane. The drug has to cross this cytoplasmic membrane to reach further inside the cell, and the passage of aminoglycosides across the cytoplasmic membrane is not a passive process. It is an active process. Remember, students, of course, these penicillin binding proteins which are shown here, they don't have any relevance to aminoglycoside getting inside the cell, but yes, they are taken up by an active transport process, and that requires energy. So that process actually where the aminoglycosides are taken inside by the cytoplasm through the cytoplasmic membrane inside the bacterial cell is an energy dependent process. One, it is an active transport, and this is one thing which we have to remember. So transport across the cytoplasmic membrane is an active transport. It depends on electron transport in part because of the requirement for a membrane potential interior negative. So this is the energy dependent process 1, and this is an active process, and this active processes are not unlimited. It's a rate limiting process and can be blocked by divalent cations like calcium and magnesium. It is also decrease the permeation of aminoglycosides inside the bacterial cell via the cytoplasmic membrane. Is also decreased by reduction in pH. That means if the pH is an acidic pH, it will not facilitate the movement of aminoglycosides inside the cell, and anaerobic conditions. So these are some conditions which will block the permeation of aminoglycosides inside the cell. So that is why the activity of aminoglycosides is reduced in the anaerobic environment of an abscess, because anaerobic conditions would not allow aminoglycosides to reach its target, that is inhibition of the protein synthesis. And as I told you, the aminoglycosides have a narrow spectrum of action. They are effective only against aerobic organisms because strict anaerobes lack this oxygen requiring drug transport system. So if they don't have this mechanism which requires oxygen, which is an active transport, the anaerobes will not be able to take up aminoglycosides, and hence they would be spared from the lethality of the aminoglycosides. You can see the normal bacterial cell, and as I told you, the bacterial ribosome comprises of two subunits, the 50S subunit and the 30S ribosomal subunit, which forms the initiation codon, and this is the transcription along the mRNA, formation of the nascent polypeptide chain which elongates, as I told you in my previous session. Now, if the same bacteria is treated by an aminoglycoside, there is some books say that the aminoglycosides, they bind to the interface between 30S and 50S, and they block the formation of the initiation complex. So this is one of the things which is very categorically, very starkly said for the aminoglycosides, that they block the formation of the initiation complexes. Rather, they form abnormal initiation complexes which are called streptomycin monosomes. They are called streptomycin monosomes. The name is kept like that because it means that it's an abnormal initiation complex, which is because of the aminoglycoside inside the bacterial cell. And the things which are negative for the bacterial survival then begin to happen. They cause abnormal codon anticodon recognition and form a miscoded peptide chain, leading to formation of aberrant proteins. Now, if the aberrant proteins are formed in the bacterial cell doesn't remain healthy at all, and these aberrant proteins, they lodge themselves in the cytoplasmic membrane. The cytoplasmic membrane, which was so firm, not allowing aminoglycosides, only allowing few molecules of aminoglycosides via its active transport, now has these aberrant proteins lodged in the cytoplasmic membrane, and that disturbs the permeability of the cytoplasmic membrane. And if that permeability is disturbed, more and more aminoglycoside molecules or drug molecules will get inside the bacterial cell, inhibit the process of bacterial protein synthesis, and that is going to be ultimately lethal. Another thing which I want to tell you, that aminoglycosides going across the cytoplasmic membrane via the active transport is called, as I told you, energy dependent transport 1, which is blocked by divalent cations like calcium and magnesium, and that transport is also decreased or blocked in anaerobic situations or in situations where there is less pH. That is called EDP1. But when these aberrant proteins are formed, they lodge themselves in the cytoplasmic membrane and disturb the integrity of the cytoplasmic membrane, allowing more and more aminoglycosides to seep in. That process, students, is called energy dependent process 2. So there are two processes involved in the transport and disruption of the cytoplasmic membrane by the aminoglycosides. So that's an indirect thing. Aminoglycosides don't disrupt the cytoplasmic membrane directly, rather they form aberrant proteins which incorporate themselves in the cytoplasmic membrane, and they disturb the permeability of the membrane. So that's an indirect action. As such, also we have some antibiotics, students, which inhibit the cell membrane action, or they are having a detergent-like action. To top the list is the new drug to join the class, which is daptomycin, which is the cell membrane inhibitor. We also have other cell membrane inhibitors like polymyxin. So they directly act on the bacterial cell membrane, but aminoglycosides have a secondary action which is called the energy dependent transport 2, wherein they disrupt the permeability of the cell membrane. See, the aminoglycosides, they target the bacterial cell from everywhere. They disturb the cytoplasmic membrane permeability. They form abnormal initiation complexes. They cause abnormal codon-anticodon recognition, so that leads to a lethal effects. Now students, we should always remember that aminoglycosides are not static in nature. Despite being drugs with narrow spectrum of action, when they are given, they are always given for bactericidal action. So let us come to in detail again of the mechanism of action. What they do, they interfere with the initiation complex of the peptide formation. They cause accumulation of abnormal initiation complexes, and these abnormal initiation complexes, since they have been brought about by the aminoglycosides, they are called the prototype. The first drug of the aminoglycoside class was streptomycin, so they are called streptomycin monosomes. As I told you, they cause misreading of mRNA, incorporation of incorrect amino acids into the peptide, resulting in non-functional, aberrant, toxic or defective protein. So protein synthesis is on for a while, but that also is a defective protein synthesis. They can also cause premature termination of protein synthesis, students, and these all activities occur simultaneously so as to cause a lethal action on the bacterial cell. So this is also another way. This is from the Goodman and Gilman. You can see the growing peptide chain. This is the 30S ribosomal unit, and these are the codons, and this is the 50S ribosomal unit. The direction of mRNA translation from 5' to 3', and this is the formation of the mature protein, which is normally occurring. But if the protein assembly is under the influence of aminoglycosides, they do three things. They block the initiation of protein synthesis. This is the black spot, shows the presence of aminoglycosides. They block further translation and elicit premature termination of the amino acid chain, and they also cause incorporation of incorrect amino acids, which leads to formation of toxic, aberrant, non-functional proteins. So this is also a diagram, actually, students. It shows the EDP2 process which I was talking about, and this is the inner membrane, this is the cell wall, and this is the outer membrane, and you can see these are the aminoglycosides, and the aminoglycosides are trying to enter the cell, and they bind to the protein synthesis apparatus. They cause incorrect amino acid incorporation by causing abnormal codon-anticodon recognition, but here only some few molecules have gone inside. So if you see the G picture, there is a formation of abnormal protein which has happened because of its effect on the protein synthesis assembly, and these abnormal proteins are going to lodge themselves in the cytoplasmic membrane or disturb the integrity of the cytoplasmic membrane, and that is going to invite more and more aminoglycosides molecules to reach inside. More and more aminoglycoside molecules reach inside means they are going to inhibit the bacterial protein synthesis, and that is what ultimately results in. So aminoglycosides, they cause abnormal initiation complexes, which is shown here, and it's called an aminoglycoside monosome, students, or it is also called streptomycin monosome. The choice is yours whether you want to remember aminoglycoside monosome or streptomycin monosome. It means the same. So the resulting aberrant proteins inserted into the cell membrane lead to altered permeability and further stimulation of aminoglycoside transport. So more and more aminoglycoside molecules get inside, and this process is called energy dependent phase 2. This concept is consistent with the observed progression of the leakage of small ions, because now the cell membrane has lost its permeability, followed by larger molecules which leak out of the cell, followed eventually by proteins from the bacterial cell prior to aminoglycoside-induced death. Students, you are yet to learn about the beta-lactam antibiotics, but yes, the aminoglycosides and the beta-lactam or a glycopeptide, either we can combine an aminoglycoside with a penicillin-like drug or cephalosporin-like drug, or aminoglycoside with another cell wall active agent, glycopeptide. Beta-lactams and glycopeptides are both cell wall active agents, and they say that if you combine a protein synthesis inhibitor, which is a sidyl aminoglycoside, with a cell wall active agent, beta-lactam or a glycopeptide, they are having a synergistic combination or synergistic effect as far as the death of the bacterial cell is concerned, and that I can say with surety that this combination is proven to be most effective for the management of enterococcal endocarditis, where aminoglycosides and beta-lactams or aminoglycosides or a glycopeptide like vancomycin are given together. Now, why they are synergistic? It is very simple, because the beta-lactams or the glycopeptide, they inhibit the bacterial cell wall, and aminoglycosides, they inhibit the bacterial protein synthesis. So if the cell wall or the outer structures of the bacteria are affected by some drug, they will allow more and more passage of aminoglycosides inside, and that is the reason for synergistic action. The synergism is usually employed for 4 to 6 weeks therapy if the physician wants to give it to a patient for subacute bacterial endocarditis. You know, bacterial endocarditis is a condition where the walls of the heart are infected by bacteria. The bacteria lodge vegetations inside, and whatever antibiotics you give, you know, they are not able to go to the vegetations and eradicate the bacteria of the vegetations, and this is a very, very notorious infection to eradicate, subacute bacterial endocarditis, and you have to have a therapy of minimum 4 to 6 weeks, and then you don't give a single drug. You try to combine aminoglycosides and beta-lactams or aminoglycosides or a glycopeptide antibiotic. Aminoglycosides with beta-lactam or aminoglycosides with a glycopeptide. The idea is combining a protein synthesis inhibitor with a cell wall active agent. So if you combine the two, they expand the spectrum, because there could be organisms to which beta-lactams and aminoglycosides both are active. They provide synergistic killing because they enhance the passage of aminoglycosides inside to inhibit the protein synthesis. And of course, if you combine the two antimicrobials, which you will learn that it prevents the emergence of resistance to individual agents, and that is more relevant when we are planning for long-term therapies. I told you subacute bacterial endocarditis, 4 to 6 weeks therapy is needed. And same for tuberculosis. You know, we don't give just one effective drug for tuberculosis like isoniazid or rifampicin. We try to combine the drugs together to delay the emergence of resistance. So that's one of the things which is followed. And aminoglycoside spectrum is purely gram-negative. Of course, it has activity against some few gram-positive organisms, but it does not have activity against strict anaerobes. And the reason is simple, because aminoglycosides cannot get inside an anaerobe, because an anaerobe does not have a drug transport system which aminoglycosides also need to get inside the cell. The aminoglycosides are active for brucella. Brucella is a disease which is rare. It is called brucellosis. It is characterized by fever and lymphadenopathies. Francella tularensis, which can cause tularemia. That's also a rare disease to happen. Klebsiella species, which can cause urinary tract infection, ventilator-associated pneumonias, and catheter-induced urinary tract infections. Pseudomonas can cause any type of infection in the hospital wards. It can cause infection on the skin of the burnt patients. It can cause one of the causative organisms for VAP, which is called ventilator-associated pneumonia. It's one of the causative organisms for many other gram-negative septicemias. So where you have to follow a treatment for gram-negative hospital-acquired like Pseudomonas, Proteus, and Klebsiella, we have to rely on the aminoglycosides. The aminoglycosides, are one such drugs. The resistance develops little later, and they are kept as reserve antimicrobials, especially for the fact that they have to be given parenterally. So there is no role of aminoglycoside with an outpatient person receiving an aminoglycoside, because aminoglycosides are usually reserved for hospital use, and they are reserved for serious gram-negative infections which are caused by Pseudomonas, Klebsiella, and Proteus. As you see, this is a figure of gentamicin, which is a prototype drug of aminoglycoside, and on the right side is the figure of tobramycin, which is also one of the drugs which belongs to the aminoglycoside class. Tobramycin is from streptomyces, so MY here. Gentamicin is from micromonospora, so MYCIN here. That's a difference in the spelling. And you see these acetylases enzyme and these adenylate enzyme and all these enzymes, these are the enzymes which inactivate the aminoglycoside. So when a bacteria develops resistance to aminoglycoside, it augments and it produces around it these aminoglycoside inactivating enzymes. In other words, they can be called aminoglycoside acetylating enzymes, aminoglycoside adenylating enzymes, aminoglycoside phosphorylating enzymes. And these enzymes, they change the structure of the aminoglycoside to such an extent that the structure is altered of the antimicrobial. And when the antimicrobial structure gets inactivated or altered, it is not able to inhibit the protein assembly in the bacteria. This cross shows that the gentamicin may not be resistant, may be resistant to one of these drug inactivating enzymes, which is acetylase 3. But yes, most of the times it gets converted into some other substance or some other thing which is not active on the bacteria, is called the aminoglycoside inactivating enzymes. Students, we told you that resistance is acquired, which is plasmid mediated, and formation of these enzymes or augmentation of these enzymes by the resistant bacteria confers resistance to aminoglycoside by the bacteria. So you can see here that the resistance is because of either impaired transport of the drug into the cell, or more important is presence of or augmentation of aminoglycoside metabolizing or aminoglycoside acetylating or aminoglycoside phosphorylating or aminoglycoside inactivating enzymes. So you can see here netelmicin, and netelmicin is protected by adenylases. It is also protected by type 3 acetylases. But I don't want you to remember that particular subtype. Nobody is going to bother you here. What we need to understand here, look at the amount of crosses here for amikacin. So amikacin is one such aminoglycoside which, students, is semi-synthetic in nature. It's a reserve aminoglycoside, and it is an aminoglycoside which is protected from most of these drug metabolizing enzymes, drug inactivating enzymes, or aminoglycoside inactivating enzymes. So this is about amikacin. It is a drug or a reserve antimicrobial, and if there is resistance developing to gentamicin, netelmicin via augmentation of these inactivating enzymes, you can be sure that for amikacin, these enzymes will not be able to inactivate amikacin. They may not be called as amikacin inactivating enzymes. You see the protection which amikacin is protected nicely by from these enzymes. As far as the resistance to aminoglycoside are concerned, amikacin is resistant to most, not all, most inactivating enzymes. Strains resistant to other aminoglycosides tend to be susceptible to amikacin, and but Enterococcus faecalis and Enterococcus faecium are highly resistant to all aminoglycosides. They are gram-negative organisms, enterococci gram-positive and gram-negative. So they would be highly resistant to all aminoglycosides. Now, if you come to the aminoglycoside antibiotics, I told you they are bactericidal in nature. They follow a concentration-dependent killing, and they have a long post-antibiotic effect. Aminoglycosides, whenever, students, you should always connect these two terms with aminoglycosides. One is concentration dependent killing, the other is a post-antibiotic effect. I told you in the fluoroquinolones, every antimicrobial agent has a post-antibiotic effect, but for the fluoroquinolones as well as the aminoglycoside, this post-antibiotic effect is a long effect, and that is an effect even if the aminoglycoside has been biodisposed of from the body via metabolism, the bacterial killing action still remains. So this is a post-antibiotic effect. I should like to replace it by a long post-antibiotic effect. That would be a more correct statement, just writing a post-antibiotic effect. So what do you mean by concentration dependent killing? Concentration dependent killing means more is the concentration of the antibiotic you give or antimicrobial agent you give, more is the bactericidal killing. So such drugs, aminoglycoside-like drugs, they qualify for one single daily dose. If you give the large single daily dose, the concentrations achieved are going to be phenomenally high, and those concentrations are going to produce rapid bactericidal action, which is going to benefit the patient, which is going to kill the bacteria, which is raising the infection. So aminoglycosides have concentration-dependent killing. That means higher the gentamicin concentration, greater is the number of bacteria killed. So therefore, high peak concentrations should theoretically improve efficacy, and they practically do also. So most other antibiotics, and that we have our beta-lactam antibiotics like penicillin, cephalosporins and vancomycin, they exhibit time-dependent killing or concentration-independent killing. Aminoglycosides and fluoroquinolones, concentration-dependent killing. Beta-lactam antibiotics, glycopeptide antibiotics like vancomycin, they observe a time-dependent killing. And what is a time-dependent killing or concentration-independent killing? Means where the extent of kill is dependent upon how long the concentration remains above the MIC. Not how much high is the concentration, how long the concentration of the antibiotic remains above the minimal inhibitory concentration. Now we come to that in a little while from now. Let us have the post-antibiotic effect. Post-antibiotic effect means a residual bactericidal activity persisting after the serum concentrations of the antibiotic have fallen below the minimal inhibitory concentration. See, for the bactericidal action to happen, each and every antibiotic should cross the MIC in the plasma, and they should, attain multiples of MIC to carry out cidal killing. But even if the drug levels are below MIC, for some antibiotics, the bactericidal action is going to continue. I told you the post-antibiotic effect for gentamicin can range up to as long as 8 hours. So that's about the post-antibiotic effect. It reflects the time required for bacteria to return to logarithmic growth. What is the mechanism behind post-antibiotic effect? Few have been able to understand this mechanism behind a long PAE or post-antibiotic effect, because even sub-inhibitory concentration of antibiotic may enhance body's own defense mechanisms by enhancing phagocytosis, and that may be effective. These properties of aminoglycoside probably account for the efficacy of high dose. I'm telling you, give a single dose in the morning, extended interval, that means you give only once in 24 hours, dosing regime for aminoglycosides, because aminoglycosides follow a concentration dependent killing. They don't have a time dependent killing. For time dependent killing, we have to repeat the antibiotic again and again, maybe 3 times in 24 hours, so that the bactericidal action should continue, and that is only going to continue till the drug levels are above the MIC. The time the drug levels remain above the MIC, not how much are they above the MIC. That is concentration dependent killing. What is time dependent killing? The time the bactericidal action is going to continue till the time the drug levels are above the MIC. So if you see here, this is the microbes minimal inhibitory concentration, and this is the area under the curve. This is the maximum concentration. So more the concentration of the aminoglycoside, more would be the bactericidal killing, as I told you. This is the area under the curve which reflects the extent of antibiotic absorption, and this is what I want to tell you. This is a credit question which is asked to you. You can see here that the antibiotics which follow the time dependent killing have to be given every 8 hourly, and aminoglycoside like drugs can be given every once only 24 hours. Now this is what let us consider that these two are the dosing regime for aminoglycosides. One is every 8 hours, the other is every 24 hours. Now, I would like to tell you students that the aminoglycosides are one such drugs which have concentration dependent killing, but at the same time they are very toxic to the vestibulocochlear apparatus, and that toxicity is dependent on the levels of plasma in the body, and that is levels of drug in the plasma, because once you give the drug from outside, the drug reaches the concentrations in the plasma, and when they reach the concentration in the plasma, from the plasma the drug concentrates in the endolymph and the perilymph of the inner ear, and the drug remains there bound to the hair cells of the cochlea, and it will only diffuse out when the plasma levels have fallen below the threshold for toxicity. So they diffused inside by a concentration dependent diffusion. Once the plasma levels were high, they diffused to the inner ear. So when the inner ear back diffusion, which should occur because otherwise there is going to be aminoglycoside toxicity, the inner ear back diffusion will occur if the plasma levels have fallen below to form a gradient for back diffusion. So let us see, this is not MIC, this is the threshold for toxicity. For gentamicin-like drugs, this is about 2 microgram per ml. 5 microgram per ml is the MIC, which is not shown in the diagram because we see that both the regimes are above 5. They are crossing above the level of 5, which means they are above the minimal inhibitory concentrations. Is it clear? So this is the threshold for toxicity, which is 2 microgram per ml. And if you see, let us see the first every 8-hourly dose. You give the dose at 0 hour parenterally, so 10 microgram per ml. So bactericidal action will continue for about 4-5 hours, and then the drug levels have fallen, and that's a time for the next dose. Again you give the dose, and again the drug levels increase, and then again they fall, again they increase, again they fall. So bactericidal killing is going to happen for 4 and 4 hours, say maybe 12 hours. And you see, in every 8-hourly regime, how much less time is the drug spending below the threshold of toxicity? Hardly 1 hour here, 1 hour here, and 1 hour here. Now let us have the every 24 hours. Every 24 hours means you have given a whole daily dose once in the morning. It has achieved a very high concentration, almost 3 times the concentration, 30 microgram per ml. And this time it is expected that bactericidal killing is at maximum, and that is going to continue till the MIC is 5 here, okay? And at the 10 hours, you can see that, or 12 hours, the drug levels are falling below the threshold for toxicity. That means the body has full 12 hours for the drug to back diffuse from the inner ear to the plasma and get biodisposed of. So that is the threshold for toxicity in a 24-hour regime. A lot of time of the drug is spent below the threshold of toxicity. Lot of time, almost 12 hours. And even if the drug levels are below the MIC, nothing to worry, because aminoglycosides as such have a long post-antibiotic effect. So when you are giving aminoglycosides once every day or once whole daily dose, once during the day, you get enhanced bactericidal action and you get less side effects also. What side effects we are considering? The irreversible vestibulocochlear toxicity. So if the drug levels remain below the threshold of toxicity for 12 hours, it's a wonderful achievement. As compared to if you give the aminoglycosides every 8-hourly, you see the less time which is spent below the threshold of toxicity. So that is why they say that once daily regime is always better for aminoglycosides, provided the patient is not a neonate, provided the patient is not pregnant, and provided the patient is not having renal impairment. So these 3 conditions are exceptions to the once daily regime of aminoglycosides. So what is the dosing regime? Traditionally, earlier they were given in 2 to 3 divided daily doses for patients with normal renal function, but once daily aminoglycoside dosing is preferred in most situations. Students, you are frequently asked about this question because it causes less autotoxicity, less nephrotoxicity, and more efficacy also, because aminoglycosides have concentration dependent killing. They cost less also because 3 times you have to give, so once daily you are giving once a day, so and it is administered more easily. So what are the exceptions of once daily? Everything has an exception. Nothing is perfect, nothing is just wonderful. His exception is pregnancy, because in pregnancy we'll have a lot of aminoglycosides in the pregnant lady's body, and that is going to cross the blood placental barrier, and they may damage the vestibular apparatus of the fetus. So that is the one problem which we don't want to subject in a special population. Same for neonates, because their kidney functions are not developed, and that could lead to accumulation of the drug, because these drugs are not metabolized in the liver. They are circulating in the body in the active form, and renal functions have to be very optimal. The third exception which I would like to mention is very important, is a low dose combination therapy of bacterial endocarditis, because data documenting equivalent safety and efficacy are inadequate. I'm talking about the synergistic combination. Synergism means that you are giving the 2 antibiotics together. So you are giving a beta-lactam or a cell wall active agent with aminoglycoside. So beta-lactams are having time dependent killing. You cannot have them just once a day. The synergism will not be achieved. So in that case, we always give multiple daily doses of aminoglycosides, because we are giving it with some other drug. And patients with renal impairment less than 20 to 25 ml per minute, normal is 100 ml per minute. So if it is a creatinine clearances are less than 20 to 25 ml per minute, accumulation of the drug is likely, and that is the reason these are the exceptions for the once daily regime. So students, in this session of mine, we have dealt upon the details of aminoglycoside bactericidal killing, how they bring about the bacterial cell death, what is energy dependent transport 1, what is energy dependent transport 2, and what is the advantage of giving a single daily dose of aminoglycoside in comparison to the multiple daily doses, and what are the exceptions of the once daily regime also we discussed. And not to forget, we also discuss the synergism which will be there between a protein synthesis inhibitor and a cell wall active agent. It can be a beta-lactam antibiotic or a glycopeptide antibiotic like vancomycin. So students, continue to read, and we'll meet sooner as and when time permits. And our institute is doing well. It is harboring many patients of COVID-19, and the patients are usually satisfied leaving the hospital. And yes, even the new therapies are being tried at our setup, which includes the plasma therapy. You must have heard in the news, and things are going positive. The only thing is, we do not know when the classes are going to begin, but till time, stay connected with us, keep reading, and good night.